Before we begin, I just want to put our poll up on the screen. There should be instructions on how to reply to the questions. The first question is, given today's rules and safeguards, would you share data on your health with a physician, researchers for developing AI? So essentially, their GDPR is in place. It's protecting your privacy and data protection. And do you feel comfortable to share data if it means the development of life-saving technology? So that's the first question. While you're answering that question, and I don't see the poll up there, but I guess it's going to go up there at some point. Okay, I see they're going to put that up in a second. But while you're answering that question, let me just introduce the panel. Maybe I can start with you, Susana. We have Susana Solís Pérez, who is a member of the European Parliament, representing Spain since 2019. And we're very lucky to have you, Susana, because I know health is incredibly important for you. Not only are you on an important group of members against cancer and fighting cancer, but you also have a very important role in the Special Committee on Artificial Intelligence and Data. So the perfect person to have on this panel today. Next to you, we have Yann. Hello, Yann. Yann Lecam is the CEO of EURORDIS. EURORDIS is rare diseases for Europe. And you, as I understand, have been the founder of that since 1997. And this organization has been looking to tackle rare diseases, which is going to be, we hope, a priority on the political agenda. In the past, you've played an important role and founding role in work on this topic in the United Nations, as well as in the World Economic Forum in Davos as well. So thank you for joining us. Next to you is Michael Bridges. Hello, Michael. And Michael's Vice President for Data Science at Optum, which is part of the UnitedHealth Group company. And Michael, I understand that you're driving data and what it means for Optum in Ireland and the UK. You lead a team looking at data architecture and platforms, and as well as the role of algorithms that will play an important role on the impact of cost, quality, and clinical impact for interventions of more than 100 patients that you operate in.
100 million.
100 million. Thank you for that correction. Very important one. And last but not least, Nicolas. Nicolas is the Managing Director of Accenture Health, Digital Health Europe, and leading that for the past 30 years as Accenture on digital health initiatives in Europe. You're looking at convergence around healthcare, and you have been involved in where that will play a role in industries such as health, insurance, telecommunications, health tech, and ecosystems. So without further ado, and I don't see our poll up there or the results, but without further ado, the topic of this discussion is going to be looking at primarily the points that the Commissioner has been talking about. We've been looking at the fundamental rights, which is a key factor. We want innovation, of course, to develop and advance healthcare in Europe and for Europe to lead in that innovation. And of course, we want the empowerment of patients in the EU. So if I can turn to you, Susana, let me ask you, as this regulation now is going to be looked at in the Parliament, can we strike a balance in that innovation and in the other side of looking at trust in the development of using data for AI? If I may ask you this question.
Thank you very much, Rai. And thank you very much for inviting me here, because the European Health Data Space is going to be negotiated. It starts now, the negotiation in the European Parliament. The file has just been allocated to the Liberty Committees. And I think from the Industry Committee and from the Environmental and Health Committee, we should also have a very strong opinion on it. Okay. And coming back to your question, I think when we talk about patient rights and privacy, I think the Commissioner was clear. We cannot water down the patient's right in the European Health Data Space. And in fact, what we are doing with this file, with this regulation, is to update the GDPR. So because now we have, as Cecilia mentioned, we have already the GDPR, where the data is protected for citizens. And what we are doing is doing a specifically framework for the data health, so which is correct, and which should allow us to have different perspectives in different countries. From this point of view, I think trust is fundamental, and we should also work on what the citizens know what is the benefit of sharing the data. I think it is important we know how it will affect, for example, the sustainability of our systems, or for rare diseases, or to cure the cancer, but we need to find a narrative in order the citizens understand what is the benefit of it. And I think the Commission is doing very well building these cases, business cases, where a citizen knows why I should share the data. Having said that, I would like to highlight the innovation way, the innovation pillar, because as you know, you mentioned before, this could be the way to have a single market, a real single market of digital product and services, health digital product and services. But we need to create this single market, and we could become a leader in digital health. What it concerns me, because it is the overlapping of different regulations we have now in the Parliament. Now we have the Artificial Intelligence Act. I was the rapporteur in the MB committee, so I know what is already the problem in the Artificial Intelligence Act and Medical Device Regulation. But on top of that, we have the Data Governance Act, the Data Act, now the European Health Data Space, and each of these regulations nominate a national body in most of them. So how can we make sure that there is no further fragmentation in our member states is, for me, the key question. How can we avoid fragmentation? How we can avoid duplicities and additional burden? That is key for us in the Parliament, and that is why the governance model, it is the most important thing we need to work on. And just to finish, this is essential for when we talk about SMEs, startups, and other companies. So if we want every citizen, but each SMEs benefit of the European health data space, we have to make sure that the framework enables it and is not an additional burden. And for me, as I see it, it will be one of the main concerns from the Parliament point of view.
I thank you very much for those comments, and I think you really hit it on the head, that this regulation can play a very important role in empowering and growing the SMEs. Right, so every member state has something to gain from this. And I'm very happy you talked about the GDPR, because if you look at Article 1.3, one of the major reasons the GDPR was created is to allow sensitive data to flow across the EU in a single market. So now the point of health is finally being addressed with this regulation. Mm-hmm. If I can turn to you, Nicolas, and I'm going to be switching back and forth around the panel. I want to ask you, as a company, and all our members are doing this, UnitedHealth Group, yourself, have been involved in some pretty major projects when it comes to healthcare. And what would you say are the main principles and key requisites, in guiding a successful implementation for the European Health Data Space Regulation? I always get tripped up by that acronym. And if I may ask you, how can we implement that both at EU level and national level? And just another question, if I may, is how can we ensure that such a regulation will be agile and how it can remain fit for purpose in the decades to come? Please.
So it seems I have the whole complexity in my hand now. First thing I would, probably it's worth saying that it's complex, right? So if you look at a very traditional non-health environment and you think about how do I leverage data, it might be simple. If you're in retail, you would take customer data, you would take previous purchases, you would take financial data, you put them in one place, you would do some advanced AI there, you would put recommendation, and then you would use it for upselling, cross-selling. Seems simple. Then obviously it's completely different here. If you look at just health in the EU, starting point is we have 27 member states. They have different languages. They have different health systems. They have different levels of maturity in digitalizing data. Some countries in either the northern part of Europe or the southern western part of Europe are very digitalized with a lot of data available. But if you look at other places, still a lot of paper processes, no more data. And if you don't have data, you cannot leverage it for AI and for whatever. And in the middle, we have some large countries which are right in the middle of big transformation programs to digitalize the healthcare systems. Some of them advancing quite fast, like in France, some others starting, like in Germany. So very diverse environment to get started. The second point is you cannot use data if you don't have data. So if you want to get started, you need to find what is the data sets available that are available right now that you can use and for which purpose, which means which kind of problems can you actually solve with available data. And these three dimensions, where, with whom, which data, what problem, is what you need to solve all together to get started. And that's where the agile part of the answer comes in. Because if you want to get started, you need to start small, because you will not have a lot of data. The problems you might want to solve, you might be able to solve right now are not necessarily the most complex ones. And then you will need to experiment with the ones that are ready, and not necessarily everyone. So that's a balance. And now that's about agile. Then if you take where we start with, we have a very good example, and I think Commissioner mentioned it, which is what happened recently in the COVID crisis with the digital certificate platform that the EU has built. Very similar to that. A sense of urgency. We needed a solution to allow Europeans to move from one country to another. And agile work at the same time building the technology to interoperate in a secure way, while defining the formats for data exchange across member states. A few member states more ready than others. So for the COVID, it was Netherlands, and then France, and then some other, with platforms that were ready to connect and start getting the first use case. So the first flight was really one flight between one place and another, and that was ready for this test. And then as soon as the starting point and the foundation were in place, then we leverage it further to other countries, to more complex use cases, and the security frameworks came in. How do you exchange and maintain certificates across member states? How do you revoke certificates, which typically was created afterwards when there was some security breach? And now you see at the moment we have a fully interoperable EU-level platform with all use cases in place. It's ready for the next crisis, by the way. Hopefully we'll not have one, but it's ready for it. There has been a decision just made recently to keep it alive for one more year. That's an example of an agile implementation in healthcare with data, member states, and countries. So in summary, how do you make this possible? Definition of agile: start small, scale fast. Smart small, available data, problems that can be solved with those data that make sense, and the right countries to get started, some large, some small, some ready, some that will need some coaching to get on board. And then put in place whatever is needed to scale fast later on, and that's where the framework is needed so that everyone knows where to go and the direction for everyone.
Thank you for that example. And I think we need to hear more of these examples. We need to know that interoperability is possible. And once people can see that's happening, then, as you said, you can scale up quickly. Can I just ask the tech team to put those numbers back up on the screen, please? We got the results from the poll, and I don't want to stray away from this discussion about data availability and allowing that flexibility. But here's a very interesting result from a very diverse audience. So the audiences that come to our events is a wide mix of not only officials, but as well as private industry and civil society. And it seems like the question in regards to, do we have today's rules and safeguards in place to encourage you to share your data to help advance AI and life-saving technologies? It's a resounding yes. It's 75% that do believe that. Please keep this up there on the screen. And I want to thank you, Nicolas, for those comments. And if I may move to you, Yann. And you know, we're now going to be looking at, we've heard from the ability of having that data to be available. Now, how would the EHDS help drive products and services that can be developed that data that can be created, how would that impact a person's life?
Before answering your question, I pick up on this questionnaire. In fact, we had a survey of the rare disease community to which 6,000 families answered. It's over 90% of the people was saying, I'm ready to share my data for my benefit or the benefit of my community, for the use or reuse of data, for health or for research purposes, as long as they are protected from undue use, not desirable uses, such as for insurance or work. So it's pretty strong. So the biggest your health problem, the more ready you are to share your data. That's what we wanted to demonstrate with this survey. So to your question, yes, for us, the European health data space has the potential to save lives, to improve our lives, but also to make it worse. So we need to be very careful about what we put into this framework so that it works. If I focus on rare disease, it's about 20 million people in EU, 30 million in Europe, 6,000 different rare diseases. In the word rare, you can already guess that the issue is rarity of patients across Europe, of experts, but also the data. The data are scattered over Europe. So for us, it's vital to be able to leverage the critical mass. So having a unique European market for data is essential. It's not a dream, a citizen dream. No, it's just our life. To reap these benefits, I would say 3 quick points. One is that for us, it's important to focus on patient digital rights, but also on the privacy and security data principles, as you rightly mentioned. But in practice, what it means is that you cannot expect the patient and the families to become engineers in data science and to know the legal framework to make all the good decisions. So it has to be friendly on the way to use it. And not have the feeling also to be a bit abused on what you're consenting to, which is a lot of what we see with GDPR today in general. So just to make it that when it becomes sensitive to your health, you will not like that. Into that also, that it's only one piece of legislation, and one concern we have is all the accumulation between the GDPR, the Data Governance Act, the AI Act, and etc. And at the end, is that becoming a maze? Is that at the end making the situation worse? Or is it clarifying by being specific on health and opening opportunities? And the full respect of patient right privacy, and I would insist on some of them that would be very important to us in the discussion. The right to privacy, the right to rectification, the right to be forgotten, and the right to data portability as essential ones. There could be more. But data portability is essential. Cross-border healthcare, today, you just cannot have it if you don't have your data with you, if you are not obliging your clinicians to look at it. Second message is that we need digital education of patients and healthcare professionals to make it happen. One of the risks that we see is that technology is in place, but the clinician or the nurse or the family don't trust it. So we need to educate. We need a certain level of literacy both for the professionals and the patients to understand their rights and obligations and manage their health data properly, again, for the use and the reuse. Lots of risk of misunderstanding around the reuse, as also Mrs. Kyriakides mentioned. 3, and last on that, is that when it comes to the creation of AI, in particular based products and services, what is essential for us is the quality, it's the safety, it's the efficacy. It's not the quantity of services. We understand quantity is there because there is emergence of new solution, competition between solutions. So that's a route of innovation. But at the end, what we need to look at is the added value from the patient perspective. And what counts for us is what is reliable and effective in managing our health. So for instance, an algorithm which only looks at a very homogeneous group doesn't help. It makes the situation worse for the vast majority of a population with rare diseases. Or if you don't look also at the gender aspects, one of the major issues in rare disease, everything is done for men, not for girls and for women. a reality. Diversity also in terms of origins in the world when people are moving. So these elements are very important for us to make it really effective.
Well, that just emphasizes the point then, Yann, that it's not just having data available in Denmark.
No.
It's having data available throughout the EU. And if you bring a single market...
And to me.
Exactly.
To me.
We're talking about 500 million citizens at plus in the EU. Imagine what you can do with that research. If I may ask you a second question, and it's a question, that we're already hearing now some pushback politically from some member states about this regulation. What would you say to that? And maybe there's some stakeholders that may not be embracing this regulation wholeheartedly. And it sounds like the importance of it is something.
First, to reinforce, as I said at the beginning, I know what I'm saying is only for people with rare diseases, but I think we can reasonably extrapolate for the people with chronic diseases in general, is that this category of citizens wants that their data be used for healthcare and for research. But what they want is to have control of their data. So that's really my message to member states. It's not to the member states. Some member states want to keep control of this data in their member states or in their hospital. Okay, what's the point? And forget about the issue of ownership. What counts is who can use the data, the custody of the data. And this is what counts for us. If I can give you a quick example, imagine that someone like the president of the board of EURORDIS, so someone we could expect have a good access. He has hemophilia, over 60 years, has been living with that all his life, clearly. He's in Italy, on the beach. Suddenly he has a major problem, an hemorrhage in the liver. He's hospitalized in an hospital in Siena. I'm blaming and shaming here. In Siena, the doctors are not specialists in hemophilia. So we have one issue which has nothing to do with data, is that they don't consult the specialist on hemophilia in another hospital. Okay, first thing, you need to convince them. But then the second thing is that the doctor's specialist of his disease and of him on liver and on hemophilia called from Denmark to discuss with them. They don't do it. And they don't want to share the results of their exam, and they don't want to use the one of Denmark. So that's why I'm saying that literacy is key. It's not only about the technology. We need also to change the mindset here. And if the patient had the data himself, then he could say, use it. Here are my results, rather than sending me to do additional exams when I'm just in pain, and it's absolutely useless to do these additional exams. And now they put him into a plane, changing twice planes to go to Copenhagen, a full long day, almost dying. What does that mean? So from data, I mean, we need to put data into context. But my point here that I want to make is that the key person is the portability, the person that can have the data with them to make the system change. That will have much more pressure than any general guidelines and regulations and whatever. Because then the family, his wife in this case, could say, hey, use that. Here are the results.
Yeah, and thank you. And I know you're not naming and shaming because this is a message for all the member states and the EU as a whole. And we saw the President van der Leyen has made it a goal for everyone to own their health records. I've yet to see my health records as a French citizen. I live in Belgium. So, I do understand your point. If I can go to you, Michael. And yes, you have solutions to 100 million patients. I'd really like to hear, that's quite an important track record. It's an impressive one. And, being a trusted steward in that, primarily in the United States, if I understand correctly, these large scale rollouts. Maybe you can just let us know, is it easier to do that in the United States, or is it kind of more to do with the hard work that's gone into creating these platforms as well for R&D? And you need trust, you need some improvements. You have to elaborate. You have to let us know in Europe, what are the learnings we can do? Can we have something like that here?
There are a number of similarities actually into the two systems. I mean, at UnitedHealth Group, as you said, we are privileged to be the custodian of not actually 100 million, that maybe is part of the work that my teams do, but over 270 million patients across the US. We are the custodians for those patient records. So very similar scale to the 500 million that we're talking about with EHDS. But that's not, the scale is not the only similarity. The systems as well. Europe, the European healthcare system, yes, there are fragmentation issues. There are different EU countries. There are different blocks. There are different hospital systems. We actually share very similar problems on the US side. Historically, when we first started building this data asset 10 years ago, we had different hospital systems using different electronic health record systems, using different coding systems, different clinical diagnosis systems. We had to harmonize all of that and bring it together. And we had to do that in such a way that we were trusted by the patients to link their data for clinical, for primary purposes, and allowed them to take their data with them when they went across a state or they went to a different hospital system. And we also had to build that asset that was trusted by the community, the healthcare community, clinicians, researchers. We needed to build an asset that they knew had the scale, the breadth of patients, but also had the depth, the richness of clinical histories, of biomarkers, so that it was useful for research, and it had that integrity for research. And that's evidenced, I suppose, the trust that the community has placed in us with our data set is evidenced by the 30 plus collaborations that we have ongoing with Mayo Clinic on rare diseases, amongst many other things, with Johns Hopkins, Harvard Medical, the National Kidney Foundation, government agencies like the Food and Drug Administration, the Centers for Medicare and Medicaid, elderly and low-income healthcare support. And a very good example recently during the COVID pandemic, our data set, this large 200 million plus live data set, was used to test the efficacy of the COVID-19 vaccine rollout by the Food and Drug Administration in the US. So I suppose, you know, when we come back to Europe and I look back on our experience over the last 10 years in setting this up, there are some key learnings, I think, that I would probably want to highlight. The first is technology, right? Leveraging technology is hugely important. Sounds obvious, but really a lot of the problems, and we've heard a lot about, you know, the logistical, the technical problems that are going to beset us as we try to do this in Europe. Different languages, different healthcare systems, security requirements, etc. There are tractable solutions using technology that we have available to us. Harmonization of codes is one problem, right? We'll have different healthcare systems in different countries using different codes, maybe even in different languages, obviously. Bringing those together into a single unified set, we've done this. We did this recently, bringing a population health management tool from the US to the UK market. We had 500,000 codes, medical codes, that needed to be mapped from one system to the other. Would have taken an army of physicians months to manually do this mapping. We leveraged natural language processing and AI to help smooth this, did it in weeks, had it overviewed by a physician. There are real tangible benefits you can get from using technology like that. Security as well. The modern approach for dealing with de-identification and anonymization and security protection would not be just to hash out people's personal identifiable information. It may well be to leave the data where it is and bring the algorithm to the data, a purely federated model, which we're now testing for moving or for using data across different geographical regions. So the data stays where it is. You bring the algorithm to the data, and then you bring back the statistical results and meta-analysis. So there are lots of these solutions that one would like to look at, I think, now, given our knowledge of what's happened in the US, bring those here to Europe. And yes, it's a very ambitious proposal in Europe. And, you know, it was said already at the start that every problem takes 10 years in healthcare. It's certainly been our experience in doing this, but it doesn't have to be that way in Europe. We have the learnings of what we've done. We have some of this technology. And a lot of the problems that we've outlined, there are tractable solutions, as I've described.
And can I ask you, Michael, just a follow-on question? If you have the algorithm moving around a federated data model, there are some trade-offs, I would imagine, than having all the data in kind of one pool. Did you notice that?
Well, not really. For AI, there are very effective distributed algorithms. If you want to build a model to leverage 100 million patients' data across multiple countries, and you want to build a model to predict the likelihood that they will develop heart failure in the next 6 months, you can actually, that algorithm is likely to be distributed anyway if you did that with the data all centralized. So you're going to be sending off the algorithm to different parts of the data anyway. You're just doing that on a bigger scale when you've got the data distributed across different geographic locations. So actually, there are effective solutions to where there are very few trade-offs to building AI in that fashion.
Okay. All right. Thank you. Thank you very much, Michael. We'll get back to you in just a bit.
Sure.
And we're now going to go for the second round of questions. And we have a second poll question as well. So I understand this poll question is going to go to our online audience. And it's very similar to this question, but it's more focused on the EHDS. So, the question is, would you see that the EHDS once in place, and that may take a while, but would you also be wanting to share your data with physicians and, of course, researchers in developing important AI? So as you answer that question, if I may come back to you, please, Susana. And I want to get a little bit more local and focused on the member state, if I may, and if I may borrow the fact that you're from Spain. How do you see this implemented in Spain and the benefits that it could lead there?
The benefits are clear, but one of the major concerns I have is how it will be implemented in countries which are very decentralized regarding health systems, like Spain, like Italy. This is my major concern. I have already asked the Commission because there are vast differences among member states, and I think the proposal is thought for a centralized system, like, for example, Finland. It could work very well, but for Spain, for Italy, for any other systems, it is more difficult. And I think we should have a more pragmatic approach, because in this proposal, what I see is that there is a lot of emphasis on the national authority. And sometimes the national authority is not the one who is close to the data. So in order to create this ecosystem of innovation, you need to be close where the data are created, close to the hospitals, close to the regions. And this is my major point. And in this case, I think it is not so simple to generate a centralized data for this national authority. I think this is difficult, and it could take a lot of time that we cannot afford. And that is why I would like to put more emphasis on sandboxes. I think sandboxes, which is taken into account in the AI Act, they have a more weight in the AI Act. We should put more emphasis on sandboxes in the European health data space in order to have a more pragmatic way to approach those countries which don't have a centralized system.
Great, thank you. Thank you very much. And if I can then go to you, Nicolas, and ask, with the aims of the health data space to best use and collect data, looking for it to be confident in reliability and for it to be shared, then it must be quality data we need, right? And do you see that there's a gap, and how do we fill that gap?
Several things. I think it's interesting to see that we shared two angles for the data part, right? One is to improve the way we develop new treatments and we improve the way care is delivered. Another one is the patient experience and the patient engagement and the risk of losing trust there. And we also, at least we have seen 2 or 3 times the EU digital COVID certificate platform, which is a good way, but everyone used it. It was interoperability across all of Europe. And I remember last year I was in vacation in Italy. We were with Spanish friends. Both of us had our certificates, went through. And we had a few American tourists just nearby. Some of them went through from New York. Some others were not going through from California because the interoperability was not in place yet. neither within North America nor with Europe. I think it's a good example of how interoperability, led the right way, enables a better patient experience, or visitor's experience in that case. So now back to the reliability and the trust part. If you want this to work, you need to have data of good quality. And there are risks there. And I think for the trust aspect of it, you remember, trust needs to be built. But last year, I remember with Francesco, we said trust, you can also lose trust if something wrong happens. So on the data side, Accenture just released, we released a study called the Technology Vision for Health just today. And we have some good examples of where trust can be destroyed very easily. One is deep fakes. We have seen, everyone has seen the Tom Cruise video where we see a completely fake video that looks like a Tom Cruise interview. Think about it, creating fake digital imagery that would actually lend to detecting or non-detecting specific tumors. And someone that would be very proud of having implemented an AI processing on some digital imagery would then suddenly be confronted with the fact that the outcomes are wrong, destroying trust. So how do you create a framework there that would prevent this? The second example that we put in our tech vision that I would like to quote is the synthetic data generation. So there is a big problem now in AI. We said there is not enough data available at scale. And if you want to train a machine learning algorithm, you need a lot of data. So in some specific private sector situation, generating data to train the model is very efficient. If you want to, for car driving, self-driving, for playing Go, then you generate fake data and you train the AI against fake data. What if we would do the same with health data? So I need quickly to develop a foundation of data sets to test a new vaccine or a new drug against COVID. I would do that with fake data, and then suddenly I would have this new drug being calibrated, and then I would discover that there is some wrongness in the data that have been used, and therefore we would say, okay, there is actually a bias. This drug, which was claimed to be effective there, is actually not effective. And we have seen in the past, we have seen in social media, a lot of noise, rumors that this specific treatment would generate a specific problem with a specific segment of population or the other way around. So we should be very, very cautious about leveraging these new techniques that AI is providing in healthcare. So we need a framework for that. So that's for data availability and reliability. Once you have the data, you start doing AI on top of it. And then there is another set of risks there. One is mislabeled data. So we know there are very different data sets of different qualities, different meaning in different systems. One single data element could have the same name, but mean very different things in one country, one hospital system, another country, another hospital system. So if you don't label the data properly, you are also at risk of having improper data sets and therefore using them to train machine learning algorithms the wrong way. That's an example. Second example that's very typical of misusing AI is the lack of industry expertise. So you put statisticians together, look at data, they don't understand the meaning of it, and they get correlation that seems to make sense if you don't know the content. They actually don't make sense if you look at it from a medical angle. That can create biases, etc. This is a set of risks. The conclusion for that is twofold. One, there needs to be a framework that define the rules of collecting reliable data and doing proper use of data, which is part of AI, but this has very specific health components. The second one, and that comes back to my initial statement about being agile, the best way to avoid those risks has always been, for everything AI, to get the practitioner involved as it is being developed, because they can capture and identify bias and create a feedback loop to improve the modeling. So do it while working. Don't do it with data scientists sitting on the side. And obviously, if you communicate on top of it, I understand the risks, the practitioners are involved. By the way, me as a patient, I trust the practitioners. We saw that before. Then I would build trust instead of being at risk of destroying it.
Okay, thank you very much. And we're coming to the conclusion of this panel. And Yann, I want to give you the final word. But before we get there, since you are here, maybe I can ask you, Michael, with your colleague sitting next to you on the panel, do you have an example of how we can tackle rare diseases?
Yeah, definitely. I mean, rare diseases is one of those areas. Obviously, a large data set is necessary. With our data asset, for example, we can confidently select 50 patients for a clinical trial that we know have the condition, rather than 500 who maybe do. And in a recent example, collaboration with the Mayo Clinic, for example, we looked at a horrendous lung condition, IPF, which is a rare and fatal lung condition. There were no sizable clinical studies to show what treatments should be effective for this. We were able to leverage our big data asset to get enough patients that we knew had IPF. There were a number of medications that they could have tried. We found, with the real-world evidence from our asset, what was most effective, and we landed on 2 drugs that actually reduced mortality and reduced hospitalization over a 2 period. You're giving people that extra lease of life with this large data. There are tangible benefits you can get from assets like that at that scale.
Oh, thank you. Thank you very much, Michael. And Yann, I want to give you the final word. So I do have a question here, but in fact, I'm just going to let you say what you want.
No, thank you. I think we can really build on your last comment, is that we're absolutely convinced of that potential because we see it in different contexts. I want to say that the federated data model is what we have been promoting within the last years in the field of rare disease in Europe, particularly when it comes to registries, real-world evidence, etc. So we're completely in that direction. And would like to insist that for the field of rare disease, we have one unique opportunity in Europe. One unique opportunity in the field of health policy in Europe is that we have created 24 European reference networks for rare diseases. They are the embryo of a European healthcare system. It's the first and only area so far where healthcare is connected across Europe, where we have already a standard of interoperability, of common data sets, and many more. So this is the perfect environment where to test the governance, where to test the tools, and to have a readiness, and then to have a good case to show it works. Because you have a lot of readiness and willingness, I would say, from the patient and the clinicians. And not only the few centers attached, it's already almost 2,000 centers of expertise attached to these 24 networks. But also, in the next 3 years, there is an in-depth work to link that within the national healthcare system or regional healthcare system, like in Italy and Spain. So we have really the potential to make it one of the user case with cancer and few other areas where we have sufficient. And what will work for rare disease will work for all, for sure.
Thank you very much, Yann. And I'd like to thank everyone in the audience. And I apologize to my next moderator for cutting a little bit into his time. And I'd like to thank the European Parliament for joining us and to continue to